Thank you very much, Lucy. Yeah, I think it's with Lily there too. So welcome to everyone that's joining, and I suspect a few more people are going to be joining as time moves forward. So welcome to today's webinar, jointly brought to you by the wonderful NNAP team and the BAPM team. I'm just going to open my slides to welcome you all, just while the last few people join. Lucy, could you let me know if my slides are showing?
Yes, they are, Sarah.
Thank you very much, Sam. So today's webinar is really to go through the recently released NNAP report and to help us all understand how we can best improve our care. And certainly as an NNAP neonatal consultant myself, I really value the support and the help that the NNAP team provide us all to improve. So I am an LNU consultant. I work in Swindon in Wiltshire, and for the last year I have been the quality lead for BAPM, and I also lead a project around preterm optimisation across the southwest of England. I'll be chairing today's webinar and will introduce our lovely array of speakers as we move through. So a little bit of housekeeping for you all. We are recording this webinar. The recording will be available on the NNAP webpage fairly soon. All of your videos and mics are disabled during the webinar, but please do use the Q&A function to ask questions. After the webinar, you'll receive a link to your evaluation form and your attendance certificate after the session. And any concerns at all, please do email the wonderful NNAP team on the email address that is shown. So just a little bit of background to put this into perspective, to really help to focus us all on the importance of what we all do, no matter what our role within perinatal care. And also to understand how important it is that we continually strive to improve. So this is Embrace data published a few weeks ago, and it shows us the trajectory in mortality across the UK for the newborn population. And there has been a fall in the expected perinatal mortality rate, but it continues to largely be driven by a reduction in the stillbirth rate. The newborn neonatal mortality rate has fallen slightly across England, but it's quite variable across the other nations. And I think as we strive to see improvements in our care processes, which Sam will cover in his data shortly, what we'd really like to see is the impact on outcomes. And I'm sure Sam will cover that we feel that there's still a lot of unwarranted variation in both the process measures and the outcome measures. So what's driving our newborn mortality? And at the moment, certainly the overwhelming portion of infant mortality is driven by prematurity. So over 2/3 of infant deaths under the age of 1 year are born preterm. And this data does not seem to be changing. Prematurity continues to be a very powerful driver for mortality. And that's why a lot of the NNAP measures that you'll see do relate to the preterm population. But I think also what's really interesting is the very strong association between preterm birth and social deprivation, and the very strong and worrying association between social deprivation and mortality. And it's really important that we look at this more. And perhaps the only way we'll be able to evaluate this properly is if we have really good ethnicity and social deprivation data. So I think one message for everyone is to be ensuring that our data capture on our electronic systems is really good for ethnicity data. So now that we know that a large driver for mortality is prematurity, and yet we know that there's this massive evidence base of often really simple interventions that we can do. Why aren't we doing them? Why is the mortality rate not changing as quickly as we'd like? And really what I love about seeing the NNAP data, I get really excited when I see it come out each year, is because it helps me in my own service and in the projects I run regionally and as National Quality Lead to try and understand this gap, to try and close this gap between what we know we should be doing and how we implement it. So the quality strategy for BAPM is really to improve the standards of perinatal care by supporting everyone involved. And JC will definitely help us to understand later how to bring together that perinatal team so that we can all work on delivering the highest quality care. We have a number of values, but I really wanted to highlight the importance of efficient use of neonatal data and how we use that to drive improvement. And that really is what NNAP does so beautifully for us. We're really privileged to have NNAP in the UK. So we have a really strong focus within BAPM on reducing inequalities in perinatal care. So that's reducing some of the unwarranted variation that there is, but it's also the inequalities of health outcomes based around women from different ethnic backgrounds and from different areas of social deprivation. And again, a plea, can we please start making sure we have increased ethnicity data on, for example, vaginates. So we've brought the resources together for preterm perinatal optimisation into this care pathway. I hope that by now this is familiar to many of us, and it really also mirrors the work that's being done within the Maternity Safety Improvement Programme for NHSE. We have lots and lots of different resources on the BAPM website. If you haven't dipped into any of our QI toolkits and you think, actually, I need some help in this area based on your NNAP data, please do go and have a look on the BAPM website. So today we're going to look at the NNAP 2021 data with Sam Audit, who I'll introduce shortly. We've got a great presentation from the team in Swansea in Wales around implementation of deferred cord clamping. And then we have, we're going to hear about the new Building Successful Perinatal Teams resource from Julie Claire Becky. So without further ado, I think this is a lovely photo of you, Sam. Sam Audit is a consultant neonatologist in Bradford and the clinical lead for NNAP. And so without further ado, I will unshare and hand you over to Sam Audit to talk about NNAP 2020.
Well, thank you, Sarah. Where did you dig that photograph up? Don't answer that. Thank you, everybody, for being here. It's great to see so many friends and colleagues from around the country. So I promise I will share some slides in a minute. I'm not just going to show you a picture for an NHS backdrop. So we'll get the right one. That's always a good thing. So hopefully you can see some slides now.
Yes, that's all good, Sam.
Fantastic. Okay, so what I'm going to do in the next 45 minutes or so, 40 minutes or so, is to try to show you some of the slides that many of you will have seen already, and try to link that in terms of what we're going to be doing in the future. We do want to have some discussion, so do put your questions in the chat and we'll try to fish them out. There's quite a lot of people registered, so we'll have to sort of see how that goes. So my intention is to be able to make slides move to start with, to describe some of the 2021 data report findings. And I want to particularly to reference some of the key findings and recommendations, and as I go through to, as I say, to discuss some things that are changing. So in NNAP, one of the things that's only one of the only constants in NNAP is that we change the order of the measures. And so in honour of that tradition, I'm going to do this in a different order to what they are in the report. So I'm going to start with some neonatal care processes, because NNAP has a reputation for doing things that people think aren't very exciting. And so here is from 2009 to 2021. It's our measurement of the timing of ROP screening by year, and you can see the pale blue columns represent success according to the old screening criteria. So you can see that we've all got quite good at screening babies for ROP according to the old, or the NAP interpretation of the old screening criteria. But we also, I'm sure, are all aware that the screening criteria have changed. So on the caterpillar plot on the left-hand side of the screen, as I look at it here, shows that a lot of services are doing 100%. So of different kinds. So red ones, NICUs, blue ones, local neonatal units, and grey ones, special care units. There's a lot of services that do 100% of babies screening on time according to the old measure. And then there are some which are less successful. But if you look at the vertical axis here, even the least successful unit is doing this in 60% or more of 60% of babies. I've indicated that the measure is going to change for the 2022 data from March onwards, from the 1st of April onwards. We're going to use the ROP screening guidance that was finally published, or haven't been around in draft form for a long time, in March 2022. And the key thing about that is that the target screening period is 1 week, and that there isn't going to be an allowance of 3 weeks, so a week either side, as there was in the previous thing. ROP screening, a little bit of a change. So what about 2-year follow-up? That's another care process that's really important. We're not brilliant, as you can see from this column chart, at managing to deliver 2-year follow-up to the babies delivered in England and Wales. In 2020, the penultimate column in this chart, and we had a bit of a drop-off. And we're seeing a gradual crawl towards, but nowhere yet near 100% of babies followed up. So less than 3/4 of babies have got even some health data into 2 years of age. So that's pretty disappointing, I think. We could probably all do better at that. And if we look at neonatal units, you can see that neonatal units of all sizes and types manage to get 100% or very near 100% follow-up rates. And there are services of all sizes and types that are less successful. And there are really quite a few neonatal units who are doing 50% or less of their babies being followed up. And that's kind of pretty disappointing, really. So we can probably all do significantly better at that. And the British Association of Neonatal Neurodevelopmental Follow-up are clearly an important partner for change in this. So nurse staffing, is that a care process? We're calling that a care process. So in 2020, the penultimate column shown here, we had a good year. We had, if we look at the shifts, the number of nursing shifts, so we say there are 2 shifts a day, that have enough nurses on them for the patients who were present in the neonatal unit at the time. It was a good year in 2020, and we fell back somewhat in 2021. So that's pretty concerning. 2021 was, of course, the second year of the pandemic. Perhaps there was the staff being moved from one department to the other, whatever that's called, going on more in 2020. Perhaps that artificially inflated it in 2020, but because we're better in 2021 than we were in 2019 rather. But that's it's clearly not great that we've fallen back on staffing, and there are lots of change partners in that, but mostly that's at neonatal unit level, isn't it? This graph's a way of showing the same thing. Again, a caterpillar plot. So the vertical axis there showing from 40% at the bottom to 100% at the top. And you can see, we shouldn't overinterpret these caterpillar plots, but Wales in 2021 data was the unit, was the network that had most of its shifts, the highest proportion of its shifts staffed according to the recommendations. But you can see there's quite a lot of variation between networks, and most networks are below their grey point, which is the 2020 data. So there's grounds for important concern there. In a way, that's sort of a way of showing the previous film. It's often said that it's much harder for the NICUs to be staffed appropriately, and there is a structural reason within the context of the measure why NICUs might be likely to perform worse. So this graph shows again the proportion of shifts that are adequately staffed. Each dot is a neonatal unit. The pink or red, they're pink, are NICUs. The blue ones are local neonatal units, and the grey ones are special care units. And it's not surprising for structural reasons, because they have fewer staff on each shift, that the special care units tend to generally do a bit better. But if you look at, and this is a measure of workload on the horizontal axis, which is the number of dependent babies. So it's a measure of workload. You can see that in the middle of the NICUs, there are NICUs that are averagely busy, that have very good staffing and very poor staffing. So really striking variation, and clearly it's a networks and a units thing, and it's a trust thing in particular to improve this. But it's not really the case that it's worst in NICUs. There's a lot of overlap between the different kinds of unit and a lot of variation within the different kinds of unit. So we wondered what we could do to better support neonatal units and particularly neonatal networks with understanding their staffing. And so we've produced these smooth network plots, which are not that easy to interpret in the slide, I suspect. But this is my my operational delivery network. And if we find my unit, which is temporarily lost to me, hopefully you can see that there's a black line below the blue where my mouse is, and that is the number of nurses that would be required to look after the babies that were present on those individual shifts. And each column is a month. And you can see that there's for most units it's mostly blue in the network, but there are important periods when it goes orange, and that's when the black line goes above the number of nurses that there were, and that's shaded orange. There's some smoothing because otherwise it would chop and change a lot. And in general, if you look in the neonatal in the NICUs within this particular network, of which there are 4, they all have a difficult time in the summer and in the late summer and the autumn. So there's one, there's another one, and temporarily not finding Albert, they're here. So they tend to all be busier at that point. And that's true also in the local neonatal units and the special care units. And so that was clearly a pressured time. And those of you who work in NHS staffing will know that's not unfamiliar. So we hope that these tools will be useful. We'll run them for a few years and see if they're of benefit. And if they're not, we'll stop publishing them. So the next group of measures that I wanted to come to is parental partnership in care. This is a new way of grouping the measures for us, and we hope it makes logical sense to you, the audit users. And the first measure that we've considered in this grouping is breast milk feeding at discharge home. The take-home message is obvious here, that the proportion of babies in this case, babies of less than 32 weeks, who are breast milk fed at discharge from hospital has not changed over the years. There's no real change. There's a little bit of bouncing up and down, but there's no real difference, and that's pretty concerning. So we've also, as you know, got a measure of the proportion of babies who are breast milk fed on day 14. And this is on the top panel on the left-hand side is another caterpillar plot showing on the vertical axis a range from well over 75% to in the mid 80s. So relatively small spread, but the networks do seem to differ a little bit. With my own network not being the best at that. But in general, about 8 out of 10 babies are receiving breast milk on day 14 of life, and some variation between the networks. You'll see if you look at the bottom plot, which is breast milk feeding rates at discharge by network, that there's much more variation in rates at discharge than there is in breast milk feeding at day 14. Overall, there seems to be a slight reduction in breast milk feeding at 14 days of age. The key thing we're going to change in our breast milk feeding measures is to include babies of less than 34 weeks rather than babies of less than 32 weeks from 2022 onwards. And that was intended to fit with MAT NeoSIP in order not to provide confusing messaging. If we look at unit level variation, there's striking variation between different kinds of neonatal unit in terms of the proportion of babies, and in this case less than 32 weeks, who receive any breast milk on day 14 of life. Perhaps these special care units with very wide confidence intervals, not very many babies, maybe that doesn't mean very much. But you can see that there's NICUs that are in the sort of 65% range, and there are NICUs that can get more than 90% of their babies receiving some breast milk on day 14 of life, which is impressive. So our multidisciplinary recommendation workshop produced a bunch of recommendations around this, and in summary, those are that all units should have an infant feeding lead with dedicated time to go with it, that there's lots of QI resources, and we signpost to some of those, and in particular it's clear that we should allow unrestricted parental access to facilitate breast milk feeding, and that's one of the reasons we thought it might have fallen back at day 14 in 2021, 2 years of pandemic with parental visiting restrictions. Many of you will be aware, hopefully all of you are aware, that we have a new breast milk measure. So breast milk use on what's intended to be day 1, but for methodological reasons has to be day 1 or day 2, and that it will be reporting from 2022 data onwards. Again, what can we do to present the data to you in units and networks that's helpful? Well, we hope that these breast milk feeding plots are helpful. Some of you may have seen these before. So this is babies in this plot of less than 32 weeks. This is an example plot from 0 to 90 days of age on the horizontal axis. And the black solid line in the middle of this plot that sort of curves downwards, that represents the babies being discharged. But otherwise each vertical line is a day, and you can see that in the first few days, some babies are nil by mouth. That proportion, that black proportion, rapidly drops down to a low level and gradually diminishes. There are some babies who don't receive any breast milk. This is an idealized net unit, it has to be said. And then there is a large bulk of babies that receive breast milk, here shaded in light green in this notional unit. And then post-discharge, and this is babies who, the lighter green, the bilious green colour there, is intended to represent babies who are breast milk fed on their last day of hospitalisation. And the ideal neonatal unit has only a small, tiny number of babies who were formula fed on their last day in the hospital. So we hope that these useful. Clearly, the idealized one isn't useful. Here's some real data. This is neonatal networks, and you can see that there's some difference in shape between the neonatal networks, and in particular, the proportion of babies who are formula fed at discharge is an obvious difference between, say, the northwest and, say, London, north central and east. But there are some obvious differences in the use of formula as inpatient and when those changes take place. And if you look at my own neonatal network, for example, it's really quite a high proportion of inpatient formula use persisting for quite a long time. So these are produced at network, but also at unit level, and we hope that they will be useful to you, and we really value your feedback on their production. And we'll run these, and hopefully they'll continue to be useful, but if they're not, then we'll get rid of them. So parental partnership in care, here's the measure that people tend to think of, which is the time of first consultation within 24 hours. Do we manage to meet the parents, get the parents to meet with a senior member of the neonatal team within 24 hours of the baby's admission? And this is any admission. So this is the whole country in this coloured panel on the left, and you can see that 19 times out of 20 we do, and that there's been some gradual in general improvement. The panels on the right make clear that we didn't report unit level outliers this year, and the panel below that makes it clear there's still quite a lot of unit level variation. But if you look, I hope you can see it, the vertical axis here is from 75 towards 80% to nearly 100%. So there's less spread than this graph might make it appear. So we're planning to report this by the number of admitted babies, and I'll talk more about cohort changes in some later measures. So we still think, and our service users certainly still think, this is a really important measure. And just because we haven't reported outliers, we hope that the units are still taking this seriously, keeping an eye on their performance. And our forthcoming more frequent reporting will hopefully be helpful to you in that regard. So here we have our measure of parental presence on ward rounds, getting controversial now. This is not universally popular measure. So this describes the proportion by years here of cases where a parent was present on one consultant ward round or more. And you can see that the majority of babies had a parent present, recorded as being present on a ward round, so on one or more occasions, and that there's been a gradual improvement in that. But our service users and our professional representatives thought this wasn't really the right measure, and so probably we thought this was more important. So the proportion of consultant ward rounds where a parent was present. And the first thing to say about this is there's a lot of missing data. So there's missing data of more than a quarter towards a third. But an awful lot of the time, we don't know whether a parent was present or not. But for ward rounds for days where a consultant ward round was known to take place, a parent was present on the ward round in almost half of them, 44%. So I think that's really quite impressive. And we're going to make this the focus of our reporting of this measure in the future. So our summary report makes some recommendations, as you'd expect, and one of those is, unsurprisingly, that we should be recording parental ward round presence. We think that there's a great opportunity for units to learn with better achievement, for units with poorer achievement to learn with units with better achievement of parental involvement in ward rounds. And we point out the obvious, namely that if we want to improve parental involvement in care, we need to ask parents for their perspective on what parental involvement in ward rounds and in care generally might mean. So involving the parents in the structure of the service, because they're the ones who are paying for it. So ultimately, there's some care process measures. Being WhatsApped by someone in the team, no doubt. So I'm aware that I need to crack on. Optimal perinatal care. So what I like to call the POP7, Perinatal Optimization Pathway 7 measures, or the NEO-SIP 7, you might call the Super 7, perhaps you want to call them that. NNAP measures 6 of these, and I'm going to talk about those briefly. We know there's some moderate evidence that that the baby's being delivered in a centre that's right for the baby's gestation and birth weight is important. Here's a column graph showing that we've got a bit better than this, but a slight fall off in 2021. So a bit disappointing. This is babies born in a hospital with a NICU, less than 27 weeks were born with a NICU. Lots of variation between networks. So this quite complicated dot graph shows, for example, my own neonatal network, one of the poorer achievers of this are not changing much, whereas other neonatal networks, for example, the East Midlands Neonatal Network in 2019 had a lower achievement of babies less than 27 weeks born in the right place, and that improved significantly in 2020 and fell back only slightly in 2021. And there, in general, there's been more movement than there's been within my own neonatal network, or that in London North Central. So 1 in 5 babies is born in the wrong place. Clearly, not all of those will be avoidable. And it might be better for the baby to be born in the wrong hospital than on the motorway. But nonetheless, there's food for thought here. So we make a recommendation that exception reporting, and we point to quality improvement resources that may be helpful, but that units and networks should do quality improvement, and my own network is certainly on with this. We plan to evolve the reporting of this measure to include the recommendations in the toolkit about twins and babies less than 800 grams. And as we're also going to report on a cohort of admitted babies rather than a cohort of babies who are discharged within a given period. So from 2022 onwards, we're reporting on babies who are admitted within a given period. NNAP has been asked to, and we are rising to the challenge of delivering more frequent reporting of the data. So we hope that'll be really helpful for people, because it will result in much more timely release of data quarterly during 2023. But it will mean that if the data isn't clean, that your data will be released in the public domain. And so that's going to be an interesting conversation, which I'm looking forward to. Keeping going through the POP7 measures, we've got quite good at delivering antenatal steroids and a continued improvement on the old standard. But as everybody, I guess, is increasingly aware of, the onus now is not for us to do this 90% of the time according to the old criteria, but to do it at least as well as average, and hopefully in an improving way compared to the new standard, which is within a week, a full course of antenatal steroids within a week of the baby's delivery, as specified in that NEO-SIP. We're again changing the cohort for this, and we are including babies of 22 weeks gestation from 2022 onwards. Magnesium sulfate. a drug, when given to the woman, shown to reduce cerebral palsy by about a third. Very impressive. We've been very good at taking this up. Look at the improvement that we've seen since 2016. A little bit of improvement in 2021. We see here at a unit level, a caterpillar plot, that there are a number of neonatal units that can apparently give magnesium sulfate to everybody. It's most impressive. There are lots of NICUs and other units that are doing that in the sort of 80%-ish kind of range, and some smaller neonatal units that are less effective at, or where the perinatal service is less effective in getting magnesium, those women magnesium exposed. So our key finding was that further modest improvement in aggregate, so in the round performance, is possible. So there's a bit more improvement possible, we think. And that's made particularly obvious by the caterpillar plot. You've got to note the vertical axis here is only 80% to sort of 92% at unit level, so at network level, sorry. So it overstates the apparent variation, does this plot? But I think it does make clear that there are those of us, including my own neonatal network, who were very good at this a little while ago, but everyone else has got so much better. Those of us down this end of the plot, need to keep on improving. The measure is evolving slightly insofar as we're moving to a cohort of admitted babies instead of discharged babies. So deferred cord clamping, now there's an exciting thing. I was going to say it's a technology, but it certainly isn't that. But leaving the baby alone for a minute or more at delivery, as you know, reduces mortality by a third. And what we found is that there's really quite significant center level variation. The average, fewer than half of babies of less than 32 weeks were exposed to deferred cord clamping in 2021, which is disappointing. It's an improvement, but it's disappointing. In the trials, it was around 2/3, a little bit more than 2/3. So if we had been able to improve deferred cord clamping to the levels seen in the trials, that would equate to 60 fewer deaths in the country a year. In England and Wales, so that's a big potential reduction in deaths, and it's likely that some of the morbidities will be improved also, although the data's not so clear about that. So we think this is a striking opportunity for continuing improvement. None of us should feel defensive about this. We should just see to how we can improve that. And the BAPM have got a really good toolkit pointing out the easy, low-hanging fruit, the things that can be done. And I think there's many good things about that toolkit. In 2022, we'll be reporting deferred cord clamping on babies who are less than 34 weeks, not less than 32 weeks, in order to fit in with MAT Neosip. And you can see that neonatal networks vary really quite a lot in the extent to which they've deferred cord clamping. So Sarah's neonatal network, the Southwest ODN, really quite good at deferred cord clamping, closely followed by Yorkshire and Humber. And there are colleagues in other neonatal networks who are all quite similar, but there's variation at centre and at network level. And I hope you'll be persuaded and motivated that there's stuff we can do about that. Keeping babies warm is a thing I'm super keen on. I hope that it's obvious from the column chart that you can see the blue has gradually improved. We think this is still a best in the world figure. We've got much better at keeping babies warm. There are far less cold babies, and the proportion of hot babies hasn't changed. So it's definitely possible to make a baby hot if you're not careful. But in general, British neonatologists are good at not doing that. So we're delighted with that and keep cracking on. The neonatal networks vary quite a lot. Look how good those people in the Thames Valley and Wessex are at that. But I'm aware of the time, and I would definitely want to leave some time for comments and questions. I wanted to say something about outcomes of neonatal care. And so again, I fiddled with the order a little bit here. So mortality, that's an outcome, isn't it? So we can show that and these are 3-year reporting periods. So this is deaths in 3-year periods finishing 2021 on the right hand side, 3-year period finishing 2020 on the next column along, and so on. That there's a slight improvement overall in mortality, but it's pretty small. We're not planning to change this measure at all. But we have said that we will try to introduce some level of reporting of the mortality at 22 and 23 weeks separately, so as not to undermine the sort of temporal stability of this measure. But we'll plan from 2023. Rachel will correct me. I've talked about an improvement over time in mortality, and here we see by neonatal networks the variation in mortality in the top panel here. So this is if you like crude mortality. So we have a neonatal network here on the left hand side, London, North Central and East, with a proportion of babies of less than 32 weeks that die that is 4%. And the neonatal network with the highest mortality experiences 8% crude mortality, so twice as much. That's pretty concerning. So the classic response to that from neonatal networks, as you will all have heard before, is that it's to do with the babies that we look after. And our approach to risk adjustment is to use a matching analysis. So that asks the question statistically, if we take the baseline characteristics of the babies that were born in one network and find comparable babies in the rest of the data set and see how they got on, then you can ask the question, how would babies in the network of interest have got on if they'd been looked after actually in a different place? And that produces a treatment effect. And if you're not engaged in the numbers of that, I think you can probably appreciate that the order of the neonatal networks is pretty similar. And so we think that means that this variation in mortality is not based on the background characteristics of the babies. So pretty concerning twofold variation in mortality. We make recommendations about that, which is that neonatal units and networks should take a quality improvement approach to evidence-based strategies such as anti-nuclear steroids, deferred cord clamping, thermoregulation, and management of respiratory disease, and that there's work to be done in terms of delivering those better. We further recommend that locally delivered, alongside our colleagues from Embrace, that locally delivered, externally supported mortality review is likely to provide lessons for units and networks to improve care and thus potentially reduce mortality. So here is a comparable plot. So that was all babies of less than 32 weeks. Here we have babies of less than 28 weeks, and essentially you see the same effect. It's a misstatement in the green box because you can see that the overall mortality for babies of less than 28 weeks is about 15%, and you see this similar doubling in rates of mortality between neonatal networks, and that it's unexplained by background characteristics of the babies. So the key finding is broadly but not exactly represented on the slide there, and the recommendations are the same. So here's a further outcome. Bronchopulmonary dysplasia or death. The panel at the top left-hand side shows again a caterpillar plot, the prevalence of bronchopulmonary dysplasia as measured by oxygen dependency at 36 weeks, or death. We present these together because they're potentially competing outcomes. And on the right-hand side, you can see the pink dots as only local neonatal units and NICUs are included in this plot. You can see that all the units on the right-hand side, those with the higher rates of BPD or death, are pink, so they're NICUs. So perhaps it seems likely, doesn't it, that that's because they look after different kinds of babies, which of course they do. This is babies of less than 32 weeks. But if we use a similar kind of case mix adjustment methodology, we can generate a treatment effect. And there are neonatal units which it appears that being cared for in a given neonatal unit means you're much more likely to be diagnosed with BPD than in some others. And even if you just ignore the LNUs for the sake of argument, you can see that there is important difference in the so-called treatment effect here. So we think that that shows that the variation is not all about case mix. We note that at ODN level, and that was at unit level. At ODN level, the same variation is obvious. We see observed rates of BPD or death vary from between just over 30% to the mid 40%. So we have a measure change, or not a measure change, a new measure, that should say, really. So we're from 2022 onwards going to report the proportion of babies under 32 weeks who never get ventilated, because there's evidence that a primary CPAP reduces the lung injury and BPD outcome measured this way. BPD, we think, is a really important outcome, but so is necrotizing enterocolitis. So for NEC, you'll be aware that in Badger you can report whether the patient was diagnosed with NEC during this admission in the discharge form, and that if you do that, it asks you to provide evidence for that diagnosis. And we had some data to that effect. And unfortunately, the proportion of units that assured their data, that told us they were confident their data was true, fell somewhat in 2021. We were lucky in 2020 that when not so much was going on in neonatal units in the early part of the pandemic, everyone was assuring their data. In 2021, that wasn't quite, we weren't quite so lucky. So you could see the assurance rate fell from 87 to 79%. So not as many neonatal units gave us confidence in their data. And the same fall in assurance is also true for late onset bloodstream infection, which a measure I'm about to come to. But the caterpillar plot on the left, same colors. Apparently lots of neonatal units don't see any NEC at all. That kind of clinically makes sense, doesn't it? Because a lot of these are special care units and local neonatal units where you wouldn't really expect there to be much NEC. But there are NICUs that report NEC rates of well in excess of 10%, and NICUs that report NEC rates that are much lower than that. And if there's a confidence interval on the dot, it means it's a unit that assured us that its data was accurate. And so we're planning a quality improvement webinar in January to look further at this data assurance process to help people to do that well. And so I'm looking forward to discussing that with colleagues then. At network level 2, there is variation in rates of NEC, apparently between less than 4% and nearly 9%. When we do a matching analysis, it's not explained by the background gestational birth weight characteristics of the babies. So it looks like the place we want to be there for that is apparently Thames Valley and Wessex, Wales, Southwest, all apparently having relatively, or particularly Thames Valley and Wessex, Thames Valley, Wessex and Wales having relatively low NEC rates. Overlapping confidence intervals for most of these, so we shouldn't get excited about being this unit versus this network versus this network, because they're really quite similar. But at and this is a matching analysis at unit level for NEC, and this is restricted to those where the NEC diagnosis is complete. In this, there's a new color. So this is surgical NICUs in green. Red ones are NICUs. That's no good for people who've got green color blindness, isn't it? It's just occurred to me. But we see important variation in both raw rates of NEC and treatment effect, suggesting that there is real unwarranted variation here. We thought it'd be fun to plot the rate of NEC amongst NICUs against the use of exclusive breast milk feeding at 14 days, or receiving breast milk feeding on day 14 of age. And there is, I think you probably agree, a loose relationship at unit level between those two imprecise measures of things that are almost certainly causally linked. But it's interesting that we can see that in such a relatively short epoch. And so there looks to be a weak relationship between the amount of breast milk feeding, so more breast milk feeding. This is bloodstream infection. And here we see this is lots of neonatal units describing 0 rates of bloodstream infection. So a 0% of babies of less than 32 weeks who experience a bloodstream infection with one or more organisms that are clearly pathogenic. So your E. coli, your Staph aureus, is there organisms of that sort. But at the other end of the distribution, we see NICUs. Predominantly, but a mixture of units and some mixing here of units with higher rates of bloodstream infection. I mentioned that the assurance is lower, i.e. this is just with the special K units taken out, so local neonatal units and NICUs only, and crude rates of infection vary. I think you could be persuaded quite a lot by unit. This matching analysis only takes gestation into account, but I hope it might persuade you that there's evidence that this is not just that baseline characteristics don't fully explain the variation that we see. Other things might. So we think this is important, and more. We all need to do more work on assuring the quality of our NEC diagnostic information. So an outcome that we've measured for the first time this year, which is clearly been missing in action in an NNAP world, is the rates of intramatricular hemorrhage, and in this case presented together with death. So this is IVH grade 3 or 4, and the grading's described for you now in Badger according to the nationally agreed definitions. And again, dots here without confidence intervals, as here, means a unit that hasn't validated its data. Only 2/3 of units told us they were confident in how they described their at this particular outcome, and there's more for us all to do in this. So our main concern about our main finding in the report is that the missing data rate varies between just under 3% to more than half. And neonatal, this probably explains some of the variation that we see. So we've all got to work on the missing data rate and the quality of our data assurance in order for this to become a meaningful and useful outcome. You say the same rate of variation in the combined outcome of cystic PVL or death. The cystic PVL is about just under 3%, 2.3%, I think. But when you combine that as a combined outcome with death, the overall is nearly 10%. And so this is clearly a really important outcome, but there's more that we need to do in terms of assuring the quality of our data before we can really say that we know what's going on in our national neonatal data set. So we hope finally that seeing your results together will be helpful. Now, this doesn't project particularly well, if I'm totally honest. But here is what we call a spine plot, and we welcome feedback about these and about all the work that we do, which we absolutely definitely change because of the feedback you give us. But here we have Bradford, so the hospital in which I work, and the black vertical line in the middle of this plot is the national rate for each of these measures that is represented by horizontal rows. So if we take, let's choose something we're good at. So if we take deferred cord clamping, the black vertical line is the national rate. The horizontal black line is the range of units reporting different rates. The black diamond is the neonatal network figure, so we can compare ourselves. We're a purple dot, the neonatal network figure, and we can see that because we're outside the grey band, we're actually outside the expected range. We're better than the expected range. All things on the right hand side of this plot are better than the expected range. If you look carefully at our other purple dots, you'll see that we're not great at everything by any means. Not very nicely shown on the slide, there's a network level plot. One of the differences is that includes mortality. And so we hope that these will be useful to you in summarizing for a professional audience, clearly not for a family audience, the results of your NNAP results. They're no good for tracking them over time, of course. So we've got lots of resources. We really welcome feedback about this. There's this summary report, which is really, really short, and then really quite a long appendix, Appendix A, which sounds a bit Orwellian. But we've got a summary report with our key messages, national and record recommendations, and then the results at a glance within that. I think, but you can tell us, but NNAP Online is where people mostly go to look at their results. That's the only place you can get them at unit level. There is this Your Baby's Care Parent and Carer Guide to the report. And we really want to encourage you to use the neonatal unit results poster. We were just agreeing the content of our posters yesterday afternoon locally. And alongside that, the opportunities to provide information to families about the handling of their information. Because whilst we are very keen to get complete capture, it's very important that we inform families about the use of their family's data. It's not identifiable, but we think that's really important. So so those are the resources, and that is pretty much all that I wanted to say. I'm going to leave that slide showing, and I'm very happy to take any questions. If indeed there's still anyone out there, it's always hard to tell with these things, isn't it? But thank you.
Thank you so much, Sam. We are still here, and yeah, that was just absolutely fabulous. There actually aren't any questions as far as I can see in the Q&A yet, but I'm hoping that some questions will come. So I can see that there's some hands going up, but you are all muted and your cameras can't go on. So please, could you put your your questions in the chat if that's okay. So just while we wait for people to type those questions in, because I can see there's a number of hands that have just gone up, so hopefully those questions will be typed in, Sam. You alluded to some of the changes in the real-time reporting that's coming, and I just wondered whether you could elaborate a little bit more about when we can expect that to be happening, what that will look like, and hopefully then we'll see some questions coming into the chat. Thank you.
Fantastic, thanks, Sarah. So close to real-time reporting, which in the first year we mean quarterly, will result in us reporting some of the care process measures. So the POP 6 or 6 of the POP 7 in the middle of next year, we hope. And exactly how that will work out technically, we're in the process of working out. It's really quite difficult. What we want to do is to report that in a way that is, we've been asked to do it in a publicly available way, but there are data suppression issues with some of the data that we handle. It's not yet fully worked out how we're going to do that. We think we have a means described whereby we can do that, but I don't want to share that with you in case we change horses in midstream. But we anticipate doing close to real-time reporting, starting with the POP 6 in the middle of 2023.
Thanks ever so much, Sam. So there's a number of comments in the chat just reflecting how much people have appreciated your talk. But a question from Louise Weaver-Lowe in the Northwest saying NNAP Online is excellent. Totally agree, Louise. Would it be possible to look at all of the networks at once rather than just picking one or two in a measure?
So that's thanks, Louise. That's definitely a thing that we can look at. One of the real challenges that we're grappling with, and it's true for the real-time reporting as well, is the sort of different needs that people have, and the more stuff, as I think's been obvious from my slightly shonky slides, the more you stuff into one page, if you like, the less truly accessible it gets. And I think we probably need to experiment further with that. So thank you for the comment, which we've definitely written down. I've had a comment by WhatsApp to say that the Q&A is not working for everybody, Sarah. So but maybe that's somebody messaging saying it is working now.
So if people could use the Q&A function rather than the chat, then we will get your questions, and I'm seeing them as I come in, and I'm publishing them. So there are a few coming in, but I think people are trying to use the chat rather than the Q&A.
Rachel, I'm trying to use the Q&As and I can't use them.
Right, okay.
In the meantime, Colin Peters says that it's not the Super 6 or the Matneo SIP 7. He says it's the Scottish 7 or the McQuick Magic Measures. But we ignore you, Colin. We'll just have it all for England, because that's the way it works, isn't it? Do we have a question?
Yes, Sam, we do, and it's one that I know that you and I have hotly debated for some time, and it's about the intrapartum antibiotics, which is part of the NNAP/BAPM whatever we want to describe it, but it is an optimization measure that's been looked at nationally. It is collected on Vaginet with some degree of variable data quality. When will it be added to NNAP, if ever?
So we've been specifically asked not to develop any new measures. In fact, we were asked to reduce the number of measures that we were producing. So it's not a question of when. It's been actively considered, and the decision has been taken not to do that. I've said that we will take that back to the methodology and data set group in order to ask the same question of what won't be exactly the same people again. The concerns that have been expressed about that are, apart from the fact we've been told we're not allowed to, that this is a maternity process being described often very inaccurately and extraordinarily incompletely by neonatal staff, and that the worry is that the absence of a maternity data flow means that there will be no potential for balancing measures, and we're in a meeting with NHS e-colleagues just this week, we're particularly concerned about the absence of balancing measures because, for example, I've shown you there a slide which shows the penetration of antenatal steroid use to very high levels. Sarah knows full well, and many of you on the call know full well, that there is increasing concern that it's a really good thing to give antenatal steroids to the right woman, but unfortunately, if you give it to too many of the wrong women, you do quite a lot of population level harm. And so, having balancing measures for these things, which includes intrapartum antibiotics, is really important. And for that, we need a data flow that doesn't depend on neonatal SHOs or nurse practitioners, because it's the antibiotics that given to women who don't deliver that's also important. So the answer to that question is not obviously.
Thank you very much, Sam. I think we've probably got time for a couple more questions. The NNAP team will endeavour to answer your questions in the Q&A. But there's one question from Rachel Salloway, Sam. Where you do match data, does that take into account ethnicity and social deprivation?
So fantastic question, thank you. So it depends which matching analysis. For the NEC and late onset bloodstream infection, which I've inarticulately tried to sort of at least show you the existence of, and those graphs are all taken from Appendix A. We've done a very primitive matching, which is described in Appendix A. It only takes into account gestation as the only background characteristic. But for BPD and mortality, yes, absolutely, ethnicity is included. And we've used maternal ethnicity as a proxy for baby ethnicity because there's a philosophical question about whether babies can have an ethnicity because it's a self-described characteristic. But leaving that to one side, baby ethnicity is not very complete, whereas maternal ethnicity is sort of the order of 80+ 80 or even 90% complete. So we've tended to use that, and we absolutely think that's important. One of the things that we have been asked to do in our new reporting is to be very clear about to describe as richly as we can the extent to which characteristics such as ethnicity and deprivation affect delivery of care. And so quite how we're going to report that during the 2022 data year, we haven't yet fully worked out, but it's really important to do that, and which is why your point, Sarah, in your introduction is super important, that we really do want people to report, particularly ethnicity. We infer deprivation from postcode data, which tends to be quite complete. So thank you very much. Please do write to me. There's only one Sam Audit, as I uncomfortably sometimes say. And we really do vary what we do because of the feedback that we get. Doesn't mean we act on every suggestion, but we're super keen to get them and discuss them with you. Thank you very much for listening.
Sam, if I could just bother you for one more question that came in offline, and it's from Cora Doherty in Cardiff, and it's about whether NNAP intends to collect outcomes on spontaneous intestinal perforation as well as NEC in the future.
Thanks, Cora. Great question. We, as I say, probably not at the minute. We're under this we're currently under this injunction. We are under this injunction to limit the number of measures that we do. I think I'm really interested in the SIP and the German data suggesting it's becoming really quite common. But I think we need to get our existing relatively new measures, NEC, infection and brain injury, to a point where they're really complete and really meaningful before we start trying to bother people too much for more. But I think it's a really good point. And in cleaning your data for rates for NEC, it'll become apparent that some of the patients that your colleagues thought might have had NEC actually had SIP. And as you work across between yourself and the local surgical centre, in my case, for example, it'll become clear that that was the case. So cleaning that data is super important, and that will give you a local appreciation of rates of SIP. But no, we don't have current plans to do that. But please do keep asking that and other kinds of questions.
Thank you so much, Sam, for an amazing review of the data. I read the report, but actually to hear you present it is really powerful. Thank you so much. I'm just going to share my slides again so I can introduce the next speaker. You heard Sam really emphasise the importance of deferred cord clamping, and one statement really stuck out from Sam's report and from his presentation, that had we been able to do more of this very simple, largely cost minimal intervention, we might have saved 60 lives across England to Wales last year. That's really powerful. So now you're going to hear from the very lovely Vanessa Macri. Vanessa is a consultant neonatologist in Singleton and Swansea, and they are doing a huge amount of quality improvement work for preterm infants. But Vanessa is going to share their work on deferred cord clamping. So Vanessa, over to you.
Thank you, Sarah. I'll try and share my presentation now. So thank you very much. As already mentioned, I have been asked to give you an overview of my unit's quality improvement project regarding deferred cord clamping. And this project is led by one of our senior ANNPs in Swansea, Gemma Davis, and she's supported by both the neonatal and the maternity team in my hospital. So I thought I will very, very briefly go through the background of why deferred cord clamping was selected as our quality improvement project, and then focus mainly on the details of what we did. We currently define the deferred cord clamping as delaying to clamp the umbilical cord for at least 60 seconds while stimulating the baby and supporting the baby's breathing if necessary. And the advantages behind this practice are that we can provide more time for the infant's physiologic transition from fetal to newborn life. And by doing that, we first of all increase the volume of placental blood that gets transfused to the infant and decrease the incidence of anemia. But the second and possibly the most important advantage is that we allow time for the baby's lungs to be inflated. And lung aeration with the cord intact results in an increase in pulmonary blood flow and improves hemodynamics and stability, and therefore results in reduction in morbidity and mortality in preterm infants. And the physiologic changes of deferred cord clamping may be particularly important for newborn babies born apneic and hypoxic, and this is the overall improved stabilization in these babies. So acknowledging all of this evidence, we looked at our 2020 NNAP results and realized that we only achieved deferred cord clamping in about 34.5% of our preterm population. So then in addition to that, we did a retrospective analysis of 24 months worth of BadgerNet data, which just confirmed our low DCC rates. So therefore, we decided to put a team together and start this project with the aim to raise our baseline rate, hopefully by 40% within a year. Our team had to be a multidisciplinary team in order for our project to be successful, as we very early recognized that in order to achieve optimal cord clamping, we need the neonatal, the obstetric, and the midwifery team to be on board, and all of the members to work really well together. So then we agreed on our interventions to achieve our SMART aim and applied QI methodology by going through PDSA cycles. So now, before going through the different agreed interventions, we launched DCC audit forms like the one that you can see on this slide. And these forms were for the delivery team to fill in and document the infant's gestation, mode of delivery, condition at birth, temperature, both on labor ward and on admission to NICU. And the reason we did that was to capture and analyze possible barriers or patterns that prevented us from successfully delaying the cord clamping, with the aim to overcome them when possible and improve practices. And as you can see at the bottom of these forms, there are boxes where the team can explain in free text what went well, what went wrong, so that we can then learn from their experience. So this is a list of our agreed interventions in the order that we actually applied them. And as you can see, we start displaying posters about deferred cord clamping, both on labor ward and in our neonatal unit, to raise the team's awareness about this new project and prompt the team also to ask questions and familiarize themselves with the whole concept. We provided all the teams with targeted teaching sessions and used our joint perinatal meetings to discuss any concerns or any questions. We also realized that the parents themselves can actually contribute massively to the project by, in a way, demanding that their infant receives delayed cord clamping at delivery. And the easiest way for us to achieve this was just to discuss that during antenatal counseling that we routinely do. So as one of the reasons for failing to do DCC was the fact that the obstetric or midwifery team forgot about it at the heat of the moment, we also managed to integrate DCC in our pre-cesarean section WHO checklist, so that now DCC is always mentioned as part of a plan before the section begins, so there are not a lot of excuses to forget about it. Our final, but unfortunately not very successful intervention was introduction of the LifeStart trolley. And as you may know, this is a medical equipment that is designed to provide a warm surface to be positioned close to the mother, enabling the baby's airway and breathing to be supported during delayed cord clamping. Unfortunately for us, the LifeStart was used very infrequently due to logistical difficulties and concerns. And some of those concerns were that the trolley was really clunky, that there were a lot of trailing wires, which was a hazard, that the cylinders were too small and needed frequent replacement, and also issues with thermoregulation, as the heated mattress being really a poor heat source for the extreme preterm infants, as it is activated by the baby's weight. So now coming to the main part, our outcomes. With regard to our outcomes, as you can see on this chart, the proportion of babies born at less than 34 weeks gestation receiving deferred cord clamping increased from a mean of 41.5 to a mean of 72.4% post intervention, which is actually a 75% increase. So the other thing you can observe on this chart is that the introduction of the LifeStart trolley did not have any effect on the DCC rates, likely due to its very infrequent use, and we therefore abandoned that. On this chart, you can see the number of babies born at less than 34 weeks gestation each month, and that's the green line. And we compare it to the number of those babies receiving DCC, and that's the blue line. And I think it's very evident how these two lines come close together after we started this project. And this effect is still sustained according to our September 2022 data. This diagram shows you again the increase in our DCC rates in 2021 and 2022, that's post-intervention, and the slight reduction in the proportion of babies getting some delayed cord clamping, but not a full minute, and the definite decrease in the proportion of babies who have their cord clamped immediately post-delivery after our quality improvement project. So finally, we also managed to minimize the gaps in our data collection, which allows for more accurate results, which is always a good thing. And this is the last slide I'm going to show you. And it shows you the breakdown of our DCC data depending on the gestational age. And as you can see, in 2019, no one in my team really considered DCC in infants that were born at less than 26 weeks gestation. However, since 2021, our DCC rate in this group of extreme preterm infants has increased to anything between 40 and 50%. Equally, you can see that our DCC rates have significantly increased post-intervention in all the other subgroups, with the least impressive effect on the late preterm infants that were born between 32 and 34 weeks, where the rate of DCC was already high to start with before the project was launched. So now during this journey, as I suppose it's expected, we face different challenges. And the first one, and possibly the most difficult one we managed to overcome, was the difference in opinion between senior clinicians and the absolute need to achieve an agreement before trying to implement a change in practice. And this was tackled by creating an MDT, as I already mentioned, to lead the project, and by organizing very frequent MDT staff meetings to start with, which addressed any differences in opinion and ensured smooth collaboration between the different health professionals. A further challenge that we have faced once we managed to convince the permanent staff that this is the right way to go was the variation of practice that kept creeping in during staff rotation. And this was dealt with by including teaching sessions during induction of new staff, and by the fact that permanent team members were actually the driving force of this project, which ensured continuity and also safeguarded the sustainability of the positive effect. As already mentioned, we faced logistical difficulties when we tried to introduce the lifestyle, so we abandoned that. And finally, on the positive side, we were very, very relieved to see that deferred cord clamping did not compromise our temperature control post-delivery, and that our normothermia rates remained high and unchanged pre and post intervention. So we're now at the point where we're planning the next phase to try and further improve our DCC rate. And one of the barriers to achieve DCC has been sometimes the hesitancy of the maternity team receiving the infant post-cesarean section to actually do delayed cord clamping if the infant is not vigorous at birth. But there's a lot of preterm babies do actually start breathing spontaneously in the first minute of life with just gentle stimulation. And we have decided that we are now going, as the neonatal team, we are going to be the ones to scrub in and receive the infants for theatre deliveries in order to assess the infant ourselves and decide about whether it is appropriate to proceed with DCC. However, we're also very aware that the main barrier that prevents us from applying DCC to the majority of our very preterm infants is our present inability to facilitate lung inflation and provide respiratory support to infants who do not start breathing spontaneously despite gently stimulating them. And for that, we're currently looking into simpler equipment that we could possibly use instead of Life Start and to try and achieve this. So in summary, I hope I have showed you that our quality improvement project was a very low cost project that can very, very easily be implemented to improve DCC in any unit, really. And that's me. Thank you.
Thank you so much, Vanessa. And certainly, if we look across the rest of the units in your region, and indeed across the whole of the NNAP region, we can see that Swansea really have done amazingly well, and to have generated that level of improvement in 1 year is brilliant. And I think it's really important that those of us who have units who aren't able to achieve this really important metric start to learn about the practical, logistical ways that teams can work together to overcome that. So just for everyone to know that we've now turned the chat on, because I know there are a number of people struggling to use the Q&A facility. So both are now on. So please do feel free to pop questions in there. And hopefully we will have some time towards the end. So Vanessa, one question for you from my lovely colleague Julie Clare in Edinburgh. Really great improvement stats. Could you tell me what happens if a woman delivers unexpectedly, for example, in the antenatal ward on triage? Does DCC still take place? I know that we've had a number of those in my own unit, so I'd be really interested to hear what you do in Swansea.
So it did happen recently, actually, that the baby delivered downstairs and had delayed cord clamping on her way upstairs, and everything was absolutely fine because the baby was born and was breathing and was kept warm. And we, for that matter, we rely on our midwifery team if we're not there to do delayed cord clamp, but they are all very aware, and they're getting more and more confident in doing that.
Thank you so much, Vanessa. I'm aware that we're a few minutes behind time. There's some really interesting comments appearing in the chat, Vanessa, so do have a look, because there's a number of people who want to get in touch and hear about different messages. And similarly, Sam, there's some questions coming into the chat for you. So I'm just going to share my slides again, and it's my really great honour to introduce a very, very good friend of mine, Julie Claire Becker. Julie Claire was the quality lead before me at BAPM and has been a real inspiration to me. Julie Claire is a neonatologist in Edinburgh and a senior lecturer at the University of Edinburgh. She has so many things that when I was putting together the bio, I found it quite difficult to know what to list. But actually, here's two of the main things that she's working on, and she's going to share the Building Successful Perinatal Teams resource with us, because this really underpins all of the improvement work that we need to do around our perinatal optimisation. Thank you, JC.
Thank you so much, Sarah, for that very kind introduction. I'm hoping that you can now see my slides.
Yes, we can. That's great. Thank you.
Great. Can you see it in slideshow?
No, at the moment it's showing it non-slideshow.
I don't know how to change that over. Can anyone help? Let me just come out of that just now.
JC, if you maximize it on your screen and then do the share window, does that not work?
Are we now sharing now?
Yeah,
Is that us?
Yeah,
perfect.
Absolutely perfect, JC. Thanks so much.
Wonderful, thank you. And thank you very much for inviting me to speak today. It's a great pleasure to talk about the new BAPM resource called Building Successful Perinatal Optimisation Teams, Improving Team Culture in the Quality Context. And my slides are a little bit unusual with the diagram, but you get the gist that this is the perinatal optimization care pathway that has been developed from the McQuick Super 7, as Colin Peters said, and is now used with BAPM and MAP NeoSIP to really describe the interventions to improve preterm outcomes that we can deliver immediately before and after birth. And there are the 4 BAPM toolkits which support this. But delivery of these interventions are not going to be as successful unless we have a healthy perinatal team culture and an effective quality context. And I want to talk about these in more detail in the coming slides. There is a growing imperative nationally to improve culture and context. Many organisational drivers for this, including various reports that have been published and inquiries as well. And I want to talk a little bit briefly about the Kirkup reports from Morecambe Bay, the Shrewsbury and Telford Hospital inquiry in 2022, and the East Kent one, which has just been published. And these reports span 8 years of inquiry, but the patients involved are many, many more years than that. But the recommendations across all 3 reports are very much the same. It's about providing person-centred care, in developing an organisational memory by improving the standard of investigation with implementation of action plans, establishing clinical leadership, training across teams and across sites and within networks, and fostering skill in complex cases and care pathways. And finally, in optimising team working so that we're avoiding silo working, tribalism and poor behaviours. And these are all features of all 3 reports. And interestingly, in 2015, in the Morecambe Bay report, Bill Kirkup wrote, "It is vital that the lessons now plain to see are learnt and acted upon, not least by other trusts which must not believe that it could not happen here. If those lessons are not acted upon, we are destined sooner or later to add again to the roll of names." And we did with the following reports, but we are kidding ourselves if we do not think that there are aspects of our own culture locally that can be improved. And this is supported really by the Care Quality Commission's report, not just this year, but in previous years that showed the maternity core service ratings. And here you can see the difference between 2021 and 2022. And you can see that the number of services, maternity services, which are deemed inadequate or requiring improvement has actually increased since last year, and this makes up about 40% of all services. So you can see that we all have areas in which we can improve, particularly around safety culture. And what is culture? Well, culture is defined as the beliefs, attitudes, and assumptions of the members of the team that result in normalized and shared ways of thinking and practicing and working and behaving, so that it becomes the way that people think around here and the way that things are done around here. But when we think about how to change culture, it immediately becomes a lot harder, a lot more impenetrable, and we become a little bit defeatist because it's intangible, it's nebulous, it's got very complex elements that are often very deeply ingrained, have been established for many years, sometimes decades. Culture exists in a multi-level way within teams and across teams, and it can be really slow to change and very hard to change. And then you add in perinatal optimization culture, and what you find is there's a whole other layer of complexity. We have multiple interrelated sub-teams, the care of the woman and her baby, so 2 patients, who are often undergoing prolonged episodes of care, which might actually start pre-conception, complex care pathways that are followed in different departmental locations by different teams and different geographical locations as well. So it all becomes quite hard. And when we think about perinatal optimization, I want to give the example. It was lovely to have Vanessa's presentation just previously and see the great work that her team is doing and that the teams around Wales are doing. But I've heard lots of people say that they actually can't start deferred cord clamping until they get the Life Start trolley, which is under order or they've put in procurement for. And that once that happens, that's when they're going to be able to manage to get to wait that 60 seconds before clamping the cord. But I want to argue that it's really not about the kit. It's importantly here, particularly with deferred cord clamping and all of these interventions, although to a certain extent as well, we're talking about place of birth and we're talking about maternal breast milk as well. But it's actually about standing together with our obstetric colleagues and midwifery colleagues and working along with them, supporting each other in our anxieties, tensions, and different priorities around preterm birth, and having shared goals, like Vanessa was talking about in the WHO checklist, talking about this being a pathway that we're going to try and achieve this extra 60 seconds. And that lends itself to understanding of all of the optimization interventions and fosters us looking at our data together and celebrating success and identifying opportunities for improvement. And I know that this is important because we do deferred cord clamping in our unit without using any equipment like this at all, but just standing alongside our obstetric colleagues. And we are able to deliver that in 90% plus of all eligible babies who come our way for preterm babies. When we're talking about the quality context, however, so that has lots of elements that are similar to culture, but we're talking about readiness for change. And I want to illustrate this by talking about admission normothermia. So we have Unit A who have realised that they've got a high rate of hypothermia in their preterm babies, and they've downloaded the BAPM normothermia toolkit. And they've gone through a process of doing the fishbone diagrams and process mapping, and they understand really that the thing that will help them reduce their hypothermia is using plastic wraps that they've not used before at all. And what they find is they've got an 80% reduction in hypothermia, and they're so impressed, understandably, by this that they celebrate their success by submitting an abstract to the BAPM conference, wherein there is a junior doctor who's halfway through their rotation in Unit B thinking, crikey, I could do the same in my unit as well. I'm going to take in plastic wraps. So that junior doctor introduces plastic wraps but finds no reduction in hypothermia. So why should there be such a difference? And it all boils down to context. So in Unit A, what happened was a multidisciplinary team was established who established shared goals. They rehearsed what they wanted to do for thermal care with sim training. They held pre-briefs where roles were allocated for thermal care. And then every so often they would regularly feedback to staff about how their performance statistics and opportunities for improvement. Whereas in Unit B, what happened is the junior doctor only had 3 months left for their attachment. It was led by a consultant who had no QI training, and it was delivered in a labour ward that was undergoing a refurb. So you can see straight away how the context is entirely different, and so you can't extrapolate necessarily the same solutions for delivering these evidence-based interventions unless you have a similar type of culture and context, or at least for the culture and context to be positive. So you're thinking to yourself, crikey, we've had 4 BAPM toolkits already that driving us forward with perinatal optimization. We've got so much work to do already. Now you're asking us to think about context and culture as well. Well, what is the evidence? Well, there is a wealth of evidence, and this is just a smattering of papers which show that where you marry up the intervention, the delivery of the intervention alongside culture and context improvement, whether that's through leadership, whether it's through simulation or whatever, that you actually achieve much greater results. And you can find the full suite of evidence in each of the toolkits that we published so far. And so coming to that, the BAPM felt it was really important to help clinicians navigate through this, as I've talked about already, intangible and somewhat nebulous idea of culture and context. And we produced this resource to support the toolkits in collaboration with NeoSIP, with wide representation from members throughout the perinatal team who are involved in perinatal optimization, as well as key organisations who are stakeholders as well. And this resource is split into 2 halves. Section 1 is where we help you to assess your own context and culture by gathering intelligence around a number of data sources, including surveys of staff, parent, families, trainees, looking at your own performance in perinatal optimization and looking at the barriers that might exist, whether you might have data from external reviews or other mechanisms such as themes from serious adverse events or recruitment and retention figures and staff feedback and questionnaires. And using that intelligence, using the data to sort of assemble intelligence, you can then work out how you might develop an improvement plan to address key elements of your context and culture that may need attention. Section 2 is really about how to implement improvement across 6 key areas. The first is in leadership, the second in person-centred pathways of care. We have effective team working and positive communication. Then there's an area of risk and safety 1 and safety 2. And lastly, we talk about data in terms of audit, benchmarking and research, and in establishing capability and capacity for quality improvement. And under each of these 3 areas, we deal with activities which we suggest you undertake, usually as a multidisciplinary team, solutions which are bespoke for your unit, so we're not prescriptive about this. These are all things that you should try on for size after you have identified what areas are requiring development within your service. And lastly, a suite of improvement stories as well, which are really helpful from people all around the country who've been very good in contributing to our call out for these. So when we think about the activities, these are just a tiny amount of what is suggested. It ranges from things like developing a relationship diagram about the different people within your perinatal team and what kind of relationships exist, which ones might be weak, which might be strong, and why are they strong? What can we learn from those strong relationships that we can use in to develop more positive relationships otherwise? There's some great online videos about psychological safety, about civility saves lives. There are some documents and resources from places like NHS Education for Scotland, the person-centred 15 steps for maternity, and some vignettes that we encourage you as groups to work through within your own teams. For solutions, again, just a handful of the things that we have available. We've got the NNAP Your Baby's Care to help improve communication with parents and parent engagement in perinatal optimization, models to enhance trust engagement, tools to help foster shared goals in preterm birth, and to develop a holistic perinatal team approach to counselling of extreme preterm births. We suggest a format for sort of behavioural standards that might be important in running multidisciplinary perinatal team meetings, and suggests how you might develop perinatal optimization guidelines across teams as well. And lastly, to come back to the improvement stories, these are all around perinatal optimization, about how different people around the country have improved their team culture, improved their delivery of their interventions by improving the context that they operate in. And these might be about establishing shared goals, or by delivering shared teaching between obstetric and neonatal teams, whether it's about supporting the junior staff in delivering perinatal optimization as well. Anyway, there's a host of these, and you probably arrived in your inbox already the draft resource as it is at the moment, with all of its links to our online resources. If you haven't looked at that already, please do. The deadline for feedback on that is the end of the month, and we really hope to have this turned around and back out with you all as teams in the middle of December, so that you can start the new year afresh. But please have a look and feedback to us, and that would be great. Thank you very much.
Thank you so much, JC, and massive congratulations on this. The more I work with teams around the region, around the country, who are working on preterm optimization, the more and more I see that actually sometimes it's the culture and the teamwork that's the big barrier, especially to some of the interventions such as DCC. And Sam has written in the chatter, you know, you make the point about DCC so well. It's not about the kit, it's about the team. And I think often that covers a lot of the questions that have been asked in the chat. So please do continue to put your questions in. I'm just going to share, Lucy, I hope this is okay with you. I hope it won't share. So I'm hoping that you can just see, I've been pulling together some points as we've been through today. And I think my take home from this, and I hope for all of us too, is that we have too much unwarranted variation in neonatal care and in neonatal outcomes. Maybe we're seeing a bit of impact from pandemic times. I think we all need to focus on improving our DCC rates. Unlike some of the other metrics, very few, if any of us, are at 100%. And we need to learn from the units and the regions who do achieve this. And I've put your comment there, it's not about the kit, it's about the culture. And can we use a QI lens to look at all of the different process measures that we need to work on to close the gap between the evidence base and implementation into practice? So I'll just unshare and hopefully come back just to see if there are a few logistical questions about the life start. Lots of lovely compliments about your presentation, JC. So unless there's any new comments coming in, I'd like to take the opportunity to thank NNAP and the whole team for hours and hours of work every day, every week, every month of the year. It is one of the most powerful drivers for change across the UK, and we're really lucky to have you all. So thank you for all that you do. Thank you for the brilliant speakers today, for being so inspirational and driving us to get better for the babies and the families across the country. The next NNAP webinar is in January, and it's all about validating and checking data and how we will work on that. Please sign up on the website. And thank you all for coming today. It's been lovely to see so many people. Lucy, is there any final housekeeping things that you wanted to cover that I've missed off?
No, I don't think so. I'll send an email out with the evaluation form and an attendance certificate, and then once this recording is available on the website, we'll send an email to let delegates know.
That's great. Thank you ever so much, and I hope you all have a great rest of your Wednesday. Thank you.